Hello, and welcome to this week's podcast brought to you by BJ Oncology. Today, we're joined by Randolph Hecht, Jasmine Mitchell, and Jingran Ji in an exclusive roundtable discussion on key highlights in GI cancers from ASCO 2025. This podcast is part of the GI channel on BJ Oncology, which is supported by Takeda. Supporters have had no influence over the production of this podcast. Please note this podcast is intended for HCPs only.
My name is Randy Hecht. I run the GI oncology program at UCLA, and I'm really fortunate to be here at ASCO 2025 with two of my colleagues who are also GI oncologists at UCLA. I'll let them introduce themselves.
I'm Jasmine Mitchell. I'm one of the GI oncologists at UCLA.
I'm Jingran Ji. I'm another GI oncologist at UCLA.
And what we're here for is really to discuss some of what we think are the most interesting abstracts, presentations, and findings from ASCO 2025. Not every ASCO has a lot of new data that really changes the way that we practice in GI oncology. I have to say that this is clearly an exception. And we'd like to sort of discuss some of the data that came out. This ranges all the way from recurrence with new drugs, old drugs, and even non-drug treatments. So, Dr. Mitchell, would you want to start talking about, since we were discussing this earlier, is that not all that benefits patients are new and expensive drugs. Right. And so there was a really interesting trial that I think really confirms a lot of what we've already been doing and is already in the NCCN guidelines. Do you want to discuss that?
Sure. So this year we had the challenge study, which took patients who had been resected and received adjuvant chemotherapy and randomized them to either handouts and educational information about exercise or an actual regimented exercise program. And they got hundreds and hundreds of patients and followed them over 3 years of actual intense exercise, and showed a pretty significant survival benefit or event-free survival benefit, where it's basically, if you look at the difference between how much oxaliplatin improved event-free survival, it's the same, if not a little bit better, in terms of the effects of exercise.
I think this is something that we've always been doing. However, this really sort of tells us, I think, two things. One is that what's in our guidelines to tell people to exercise has now finally been validated, because it previously had been only in retrospective studies. The other thing, I think, as you pointed out, which was really, important, is that this was a structured program. So the question that comes up, and from a cost effectiveness standpoint, we think of how much medications to cost, how much side effects of medications may cost. And I think it was $3,000 to $5,000 per patient or something, which in the grand scheme of things, a number of years of dollars per year of life saved. And the other thing that I think you alluded to that was really important is that this intervention is good for other things as well, but the improvement was actually in relapse-free survival. And so it wasn't just that people weren't dying of heart disease or strokes, it actually had a colon cancer.
It had a colon cancer. I think
effect.
This is probably generalizable to all cancers, but we know now, we have actual data in colon cancer that real regimented exercise has a benefit. Another part of this regimented exercise is people got to choose which kind of exercise they could do, which then helps with compliance. So people are more likely to stick to an exercise they enjoy in a regimented way. And I think that's amazing for not just cancer, but for cardiovascular health. And
Dr. G, this actually overlaps a lot with what you do, because a lot of your research, overlaps with this. How does this change what you would do when we get back to Los Angeles and treating your patients?
Yeah, I think a big part of the study really showed that just counseling patients and giving handouts alone may not be sufficient. I think, really needs that extra level of monitoring and patient engagement to really get them through the 3 years of exercise intervention.
I think of the number of hours I spend discussing this and documenting this with patients. And, I think you're right. You may need to go over and above. There wasn't another arm where they did not counsel patients. So maybe still counseling patients, may help. Any idea about the mechanisms of action with this? Because I can think of things, but I don't think there's any data.
Yeah, not a lot of data, but there's, exercise, it reduces inflammation. There's some data, it clears cellular senescence. So potentially on the tumor level, it could improve your immune response, your immune surveillance, and maybe even eliminate dormant tumor cells or create a microenvironment where it's not favorable for them to come back.
The only way I can think of how this must work is immunologically, because you're curing patients. The only other question is, will we get this paid for? At least in the United States as well as other parts of the world. We also hopefully have time for a couple other, I think, really important abstracts. Since I started with you, Dr. Mitchell, Dr. Ji, what did you think about the ATOMIC trial?
Yeah, I think the data in that trial, so that trial basically looked at individuals with MSI-high or MMR deficient colon cancer, patients who had resection, and they added, I think it was atezolizumab to adjuvant FOLFOX chemotherapy, and showed a fairly favorable both event-free survival and I believe overall survival benefit. So, as clearly statistical significant benefit. I think the question is, with the recent data and the landscape of our treatment, how does this fit into our treatment algorithm? Because of the niche data showing ipi-nivo as a neoadjuvant treatment for these patients had a very favorable event-free survival, and the overall survival, I think it was 100% almost. Where does it come in where we have patients who we get to resection who are at stage 3
I think
and then added
there are two things. One, also to point out that MSI-high, while only about 3% of metastatic colon cancer, is a higher percentage, 10% or so, of patients with earlier stage cancers. But the other problem with the preoperative data so far, while it looks wonderful with basically 100% recurrence-free survival, we still don't have that long-term data. And I have to give the cooperative groups credit for doing a trial that would have not been possible without federal funding from the National Cancer Institute, to be able to put together a large trial that now changes how we treat our patients.
I also think one thing, to Dr. G's point, is when you're talking about neoadjuvant versus adjuvant treatment, generalizable to people outside of academic centers, a lot of times we're not getting MSI status in the forefront, and we don't have that information. So it's good that we have data for an option in the adjuvant setting.
And then the other question that comes up, and I think you alluded to, was the role of chemotherapy. We know that patients who have MSI-high tumors, actually chemotherapy works less well, and those tumors are more resistant to chemotherapy. So I think that, the problem is that we have the data that we have. But I think that I think the next set of trials have already designed themselves. So then going back to both of you, the other, I think, really interesting trial in the GI space was MATTERHORN. And so we use the checkpoint inhibitors in the metastatic disease, which help. But, when we don't get the great, wonderful results that you see necessarily in other tumors. So bringing it up front in other diseases, makes a lot of sense. Yet in adjuvant and perioperative trials, they've really failed to show any benefit. And Dr. Janjagian presented the MATTERHORN data. And then Dr. Mitchell, do you want to start? Just what did you think about that? So that was a randomized perioperative trial.
Yeah, standard of care is using FLOT in the perioperative setting, 5-FU, leucovorin, oxaliplatin, and docetaxel. This regimen can be pretty difficult for patients, but we've now shown as of last year, the ESOPEC trial, that it's superior in the esophageal or GJ adenocarcinoma. And this study then looked at adding the durvalumab in that perioperative setting, as well as more prolonged durvalumab after ending chemotherapy for, I think, a year total?
I think that's right.
And the data looks pretty good in terms of event-free survival. There isn't OS data yet.
It's right. But there is truly basically, if you recur, you're going to die of gastric cancer. So just to finish up, one of the questions, this is for both of y'all, is there have been similar trials that were not successful. And I've had discussions with colleagues who wonder whether or not, I don't think there's anything specific about durvalumab versus other PD-1 or PD-L1. Any idea why this was, other than just statistical, trials just statistically sometimes are positive. Any other thoughts why this might be positive while the others were negative?
Yeah, from my experience, at least between the PD-L1, PD-1 inhibitors, there's not a huge difference. So I think this may be due to the backbone chemotherapy from other trials. So they really focused on FLOT, which is our current best standard of care versus some of the other ones use a little bit different.
I think it was a Keynote 585, which was, but also most of those were not FLOT. You pointed out that this was FLOT. So once again, we knew the top line was positive. So going back from Chicago to Los Angeles, what I would say is that this has actually already started changing our standard of care and is now the new standard of care in treating these patients.
I would also say that we do use immunotherapy in a metastatic setting. So it's not super surprising that you can use it in the neoadjuvant or perioperative setting because we can suggest that these cancers have some immunogenicity.
And like melanoma and others, that clearly the earlier you start, the better. In some ways, the question was, why did it not work better with the other trials? With the other trials, either adjuvant or perioperative. And maybe as Dr. Ji pointed out, it may just be the interactions with the chemotherapy.
Thank you for listening. We hope you enjoyed this podcast. If you'd like to stay up to date with the latest news in oncology, you can subscribe to our weekly podcast on Apple, Podbean, or Spotify. Follow us on X, formerly Twitter, @BGOncology to join in the conversation, and make sure to check out bgoncology.com for all of our exclusive coverage on ASCO 2025.